Hi, this is Kim Nash, forensic nurse and trainer for the Colorado Sane Safe Project. Welcome to the update for the Colorado Sexual Assault Evidence Collection Protocol. This protocol was recently updated in an effort to maximize the continuity of care for patients who have experienced sexual assault and was modeled after national best practices. Healthcare professionals, in concert with other disciplines who are a part of the multidisciplinary response to sexual assault in Colorado, developed the following approach to assist Colorado's medical community in the care of sexual assault patients. We are offering this webinar in an effort to review the components of the kit and specifically to highlight the changes that have occurred. Just a reminder as we start out, the medical care and treatment of the patient is always our primary concern. Any forensic sample collection should be a component of the care we offer the patient, but medical needs must come first. While it is up to each patient to determine whether she or he wants evidence collection completed, when it is done, it can be an important piece in the criminal justice response and therefore must be done in a manner that ensures meeting the necessary standards for use in the investigation and possible legal proceedings that may occur. A review of some of the basics. The chain of custody of evidence is a record of individuals who have had physical possession of the evidence. Documentation is critical to maintaining the integrity of the chain of custody. Maintaining the chain of custody is vital for any type of evidence. In addition, if laboratory analysis reveals that DNA evidence was contaminated, it may be necessary to identify persons who have handled that evidence. The Colorado kit chain of custody remains printed on the front of the kit. In addition to patient information, the examiner has an area to sign date and time. The person they are releasing the evidence to must also sign date and time the evidence. At the bottom of the kit is an area where you list the steps that you did not collect. That way the crime lab understands that if there is not an item in the kit, it wasn't inadvertently left out, you purposefully did not collect it. It is also prudent to document in your medical record the time and the person you released your evidence to. Again, reviewing some of the basics. Evidence must be stored appropriately so that the composition of the materials inside is not altered, degraded, or contaminated. If the packing is altered, then it needs to be documented in writing, such as when you need to repackage if opened and sealed again. If you are storing evidence, then there must be limited access and there must be a record regarding the disposition of evidence. Typically, sexual assault patients fall into two categories, acute and non-acute. Acute cases occur within the evidence collection window, while non-acute rarely involve evidentiary collection, but may require an immediate evaluation. The Colorado Protocol says that evidence may be collected up to 120 hours after a sexual assault in the adolescent adult patient population and up to 72 hours post-assault in the prepubescent population. Please note that this time frame is solely related to evidence kit collection. Patients may seek care weeks or even months following an assault with complaints, such as possible sexually transmitted disease or pregnancy, and should be offered appropriate care whenever it is sought. In addition, there may be circumstances in which the medical professional determines evidence collection is warranted beyond the time frames just mentioned. For instance, if you are caring for a patient that was assaulted and held against their will, unable or not allowed to bathe, and they are beyond the 5-day time frame, evidence collection may be attempted, and this would be appropriate. You collect forensic samples based on the medical forensic history of the patient and your physical assessment. You can do an exam whether or not you have a kit and whether or not the patient requests that you collect the samples, not based on the directions in the kit. Remember the person you are caring for, and consider that kit is a toolbox, if you will, with tools in it that will allow you to collect, package, and preserve samples for your patient. The Colorado kit allows you to collect or attempt to collect both physical and biological evidence. Examples of physical evidence includes hairs, fibers, glass, paint, or other trace evidence. Photographing the area trace evidence or physical evidence is retrieved from provides documentation of the collection and may assist in the investigation of the crime. Biological evidence examples include blood, semen, saliva, bone, hair, skin. Remember, evidence is more than DNA. It is any data that is presented to a court or jury in proof of the facts. This can include testimony, your medical records, your photographs, and other documents or objects. Just one more reason why a medical exam outside of the evidence collection window is relevant. And of course, even though many of you listening to this already understand this, we need to say the golden rule of evidence collection. You must seek informed consent for the evidence collection process to proceed. Some of the other fundamental rules to follow when collecting evidence. Gloves. You will need to wear powder-free gloves to assure that there is no contamination of the evidence with the powder from the gloves. Change your gloves frequently and deliberately between any evidence collection items. For example, when you are collecting swabs and move on to the next body surface area, change your gloves. Clothing. Collect each item separately. Dry the items before you fold them up and place them into paper bags, not plastic, as it can cause mold or bacterial growth issues that will destroy DNA. If you have to cut clothing, and this does happen when there is severe trauma, cut away from the sites of injury, not through, along the seam so that the most evidence can be obtained from the damaged area. And in general, all evidence must be sealed and labeled on the outside of the bags or envelopes. Don't wash any part of the patient's body before collecting evidence. If the patient has already washed or cleaned up, simply note that in your medical record. If they're feeling bad or guilty about this, assure them that that's normal victim behavior and we expect them to want to clean. It's okay if they have, and we will still attempt to collect evidence despite the fact. Do not write directly on the specimen when you are labeling it. You can use patient labels if you need to and then apply them to the bags or container or envelope. Attempt to dry all evidence. I said that before, but it is very important. And if you cannot dry something entirely, and this does happen, you need to note it to whomever you pass the evidence to so that they can relay that information to the lab processing the evidence or to the facility that is storing the evidence so that further drying can take place at that site. Remove foreign bodies using gloves or rubber-tipped forceps to avoid damaging the foreign body, which may interfere with the analysis. While the goal of this evidence collection protocol is to provide consistency in the process, providers must recognize that there will be occasions when certain specimens may not be collected, where the order of collection may differ from the kit's instructions, or where other deviations from this protocol prove unavoidable. Because patient care is individualized and evidence-based in nature, the procedures contained in this protocol may be altered to fulfill the scope of a particular patient's consent, care requirements, and concerns. Accommodation is appropriate, and the clinical rationale should be well documented in the medical forensic record. As with all other aspects of the medical forensic exam, the collection of evidence should occur in a manner that is patient-centered, preserving patient autonomy and dignity throughout the process. It is equally important to understand that there are significant acute and long-term health consequences associated with sexual assault, regardless of whether a patient requests evidence collection. Therefore, every patient should be offered an evaluation, not just the ones requiring evidence collection. Proper evidence collection assumes that you have the tools you need to properly collect, including the kit, gloves, sterile water or sterile saline, seals, labels, and packing materials. Please remember, if you choose to utilize saline instead of water, it's a good idea to state that on the crime lab forms, as saline can cause crystallization of the samples you're collecting. Did you know that clothing frequently contains the most important evidence in a case of sexual assault? The reasons for this are twofold. 1. Clothing provides a surface upon which traces of foreign matter may be found, such as the offender's semen, saliva, blood, hairs, and fibers, as well as debris from the actual crime scene. While foreign matter can be washed off or worn off the body of a patient, the same substances often may be found intact on clothing for a considerable length of time following the assault. And 2. Damaged or torn clothing may be significant. It may be evidence of force and can also provide laboratory standards for comparing trace evidence from the clothing of the patient with trace evidence collected from the suspect or the crime scene. When the determination has been made that the victim's clothing contains possible evidence related to the assault, with patient consent, those items should be collected. The patient has the right to refuse to turn over any article of clothing. Underpants of the female victims of sexual assault where penile vaginal penetration has occurred should always be collected if the patient is seen within 120 hours of the examination, even if the patient has changed underpants since the assault. If it is determined that the patient is not wearing the same clothing, the examiner should inquire as to the location of the original clothing. This information should be given to the investigating officer so that he or she can make arrangements to retrieve the clothing before any potential evidence is destroyed. It is important that the treating facility have access to clothing the patient can wear home if his or her clothing is collected for evidence. Disposable paper hospital clothing is not acceptable. If there is no clothing available, many retail stores will make donations or contact your local crisis center and ask them if they can be of assistance. In the process of criminal activity, different garments may have made contact with different surfaces and debris from both the crime scene and the offender. Keeping garments separate from one another permits the forensic scientist to reach certain pertinent conclusions regarding reconstruction of criminal actions. Therefore, each garment should be placed separately in its own paper bag to prevent any cross-contamination. The clothing collection step has not changed with the updated protocol, but to review, utilize the 2 paper drapes that come in the kit. Place the first drape down on the floor. This will later be discarded as it may pick up trace off your facility floor. Place the second paper drape on top, and this is where your patient will stand and disrobe. If trace falls off while disrobing, the top drape will collect the trace. Each item of clothing should be packaged in its own paper bag. Each facility should obtain large paper evidence bags from local law enforcement authorities or evidence supply stores, as these are not included in the evidence collection kit. Of course, use gloved hands. Seal each bag with tape, not staples. And each bag should be labeled with the patient's name, the date and time collected, the item contained in the bag, the case number, and your initials. The top paper drape should be collected with a pharmacy fold and either placed in the kit or in its own paper bag. Many of you already know what a pharmacy fold is, but for those of you who don't, we will try to demonstrate it with these still photos. You are basically taking each edge of the paper or drape and folding it in towards the middle. So, take one edge, your first edge, and fold it in towards the middle. Then take the next edge and fold it too in towards the middle. And then the next. And then the last. Your end product will be a bindle that has no open edges, thus decreasing the chance that trace will fall out. The most common items of clothing collected from patients and submitted to crime laboratories for analysis are underwear, hosiery, blouses, shirts, and slacks. There are also instances when coats and even shoes must be collected. These items should only be taken if the patient wore them at the time of the assault and they likely contain evidence in the case. A patient's wallet, cash, and credit cards should not be taken. A patient's jewelry should not be taken. If the examiner believes material has been transferred from the offender onto the victim's jewelry, the jewelry should be swabbed using sterile water or saline and swabs and packaged appropriately as part of the evidence collection kit. After placing the clothing in separate paper bags, fold them closed with 2 folds and seal with evidence tape. You should initial the tape in several places, signing partially on the tape and having your initials come off the tape onto the paper bag. This makes it more obvious when the bag has been opened. Each bag should be labeled with the patient's name, the date, time the clothing was collected, as well as a brief description of the contents of the bag. Here we see the nurse has collected a pair of white underwear. Step 2. Trace evidence. This step has not changed with the new protocol. When caring for a sexual assault patient, there may be fibers or material that are found related to the assault. This is identified as trace evidence. These materials can help to corroborate circumstances and provide evidence beyond DNA. Place any hairs, fibers, or other materials, if found on the victim or examination table, in the bindle provided. Fold the bindle to contain the trace evidence and return to envelope. Seal and fill out all information requested on the envelope. For large quantities of trace evidence that don't fit in the bindle and envelope, you may opt to utilize a larger container, like a sterile urine cup, as seen here. With all steps, be sure to wear gloves in the collection of trace evidence, changing between each sample. So before we go any further, let's discuss smears. There are 4 different evidence collection steps in the Colorado kit that involve smears as well as swabs, so let's take a moment to discuss smears in general. Swab and smear collection procedure. The purpose of making smears is to provide the forensic analyst with a non-destructive method of identifying semen, which is accomplished through the identification of the presence of spermatozoa. If no spermatozoa are present, the analyst will then proceed to use the swabs to identify the seminal plasma components to confirm the presence of semen. If patients must use bathroom facilities prior to the collection of these specimens, they should be cautioned that semen or other evidence may be present in their pubic, genital, and anal areas, and to take special care not to wash or wipe away those fluids until after the evidence has been collected. The number of tests that lab personnel can perform is limited by the quantity of semen or other fluids collected. Consequently, 4 swabs should be used when collecting specimens from the oral, anal, and vaginal cavities. When taking swabs, the examiner should take special care not to contaminate the individual collections with fluid or matter from other areas, such as vaginal to anal or penile to anal. Depending upon the type of sexual assault, semen may be detected in the mouth, on the body surface, vagina, or anal cavity. However, embarrassment, trauma, or a lack of understanding of the nature of the assault may cause a patient to be vague or mistaken about the type of sexual contact that actually occurred. For these reasons, and because there may also be leakage of semen from the vagina or penis onto the anus, even without rectal penetration, it is recommended that the female patient be encouraged to allow examination and collection of specimens from both the vagina and anus. In cases where a patient is certain that contact or penetration involved only 1 or 2 orifices, or in some circumstances no orifices at all, it is important that the victim is able to decline these additional steps. Each of the oral, vaginal, penile, and anal collection envelopes contain the applicable slide to create the smear. When swabs are collected from each of these orifices, all 4 swabs collected should be utilized to make the appropriate smear by placing the cotton end of the collected swab in the center of the slide and smearing the center of that slide with the collected specimen. Care should be taken that the correct side of the slide is used to make the smear. The correct side of the slide should be indicated by a label marked oral, or vaginal, or penile, or anal. The smear should not be fixed or stained. Okay, so now back to step 3, which if you recall is oral swabs. This step has not changed with the new protocol. In cases where the patient was orally penetrated, the oral swabs and smear can be as important as the vaginal or anal samples. The purpose of this procedure is to recover seminal fluid from recesses in the oral cavity where traces of semen could survive. Holding 4 swabs together, swab the oral cavity, including the gum line and inside the cheeks. Attention should be paid to those areas of the mouth, such as between the upper and lower lip and gum, where semen might remain for the longest amount of time. Prepare the oral smear by wiping all 4 swabs across the middle surface of the labeled glass slide. The smear should not be fixed or stained. Allow oral swabs and smear to air dry. Close and seal the slide holder and return to kit. Return dried swabs to the oral swabs and smear envelope. Seal and fill out all information requested on the envelope. Once the oral swabs have been collected, have the patient rinse their mouth and wait 30 minutes before collecting buccal swab samples, which is step 13. Step 4. Foreign stains on body swabs. This step did not change with the updated protocol. Semen is the most common fluid deposited on the patient by the offender. There are also other fluids, such as saliva, which can be analyzed by laboratories to aid in the identification of the perpetrator. It is important that the provider ask the patient about any possible foreign material left behind and examine the patient's body for evidence of foreign matter. If fluids such as saliva, seminal fluid, and dried blood are observed on other parts of the patient's body during the exam, the materials should be collected using 2 swabs. A different set of swabs should be used for every fluid collected from each location on the body. Oral contact with the victim's breast or genitalia is common. It's important to ask the patient directly if and where the offender put his or her mouth, or where the suspect ejaculated. If the patient is not bathed or showered and contact has occurred, or if the patient is uncertain, collect the specimens. Dried fluids are collected by dampening the swab with sterile water or saline and swabbing the indicated area. After allowing the swab to air dry, it should be returned to the envelope provided. In the event multiple sites require collection, the examiner should obtain additional swabs and envelopes from the hospital supply and label accordingly. Seal and fill out all information requested on the envelope. I wanted to share an example of foreign stains. I recently testified in a case where a 23-year-old female reported a vaginal penile assault. She awoke to the perpetrator penetrating her, and as she pushed him off, he pulled out and ejaculated on her abdomen. She didn't disclose the assault until 3 days post-assault and reported showering twice. She felt quite guilty over the fact that she had showered twice and actually stated during the exam, quote, "I'm sorry I showered. I scrubbed my stomach twice because I felt like I couldn't get clean." I first offered reassurance that it is normal for patients to bathe after an exam and that it was okay. I also documented directly her quote about not feeling like she was able to get clean. I then collected abdominal foreign stain swabs anyway, as even though the assault was 3 days prior, she still fell into evidence collection time frame. Perpetrator DNA was found on those swabs, and this case did go to trial. The perpetrator was found guilty. Just an example of how important foreign stains can be and how important it is to not assume DNA will not be present. Bite mark procedure. Bite marks may be found on patients as a result of sexual assault and should not be overlooked as important evidence. Saliva, like semen, may demonstrate the DNA profile of the individual from whom it originated. Bite mark impressions can be compared with the teeth of a suspect and can sometimes become as important for identification purposes as fingerprint evidence. The collection of saliva and the taking of a photograph of the affected area are the minimum procedures that should be followed in cases where a bite mark is present or believed to be present. The collection of saliva from the bite mark should be made prior to the cleansing or dressing of any wound. If the skin is broken, swabbing of the actual punctures should be avoided when collecting dried saliva. It is important that photographs of bite marks be taken properly. An individual deemed appropriate for the situation and who has sufficient photography skills should be contacted immediately to take photographs of the bite mark evidence utilizing an American Board of Forensic Odontology No. 2 standard. Saliva is collected from the bite mark area by moistening 2 sterile swabs with a minimum amount of sterile water or saline and gently swabbing the affected area, following the same procedures as instructed for other dried fluids described in the previous step. Step 5. External genital swabs. This is a change in the Colorado Sexual Assault Evidence Collection Protocol. It has been added as a new step. If the circumstances of the assault suggest there has been contact between the victim's genitalia and the offender's mouth or penis within 5 days of your examination, there exists the possibility that saliva or seminal fluid may be found on the patient's external genitalia. In this instance, the 2 cotton-tip swabs in the envelope should be moistened slightly with sterile water or sterile saline, and the entire pubic area should be swabbed. The swabs should be dried and packaged appropriately. Seal and fill out all information requested on the envelope. With the prepubescent or pediatric patient, external genital swabs should be collected in both the male and female peds patients. In the female prepubescent patient, these external genitalia swabs are collected instead of the vaginal and cervical swabs. Step 6. Pubic combings. This step has not changed with the new protocol. Pubic hair can retain trace evidence from a sexual assault. For this reason, collection of pubic hair combings may be beneficial. If the patient is prepubescent or has shaved her or his pubic hair, external genital swabs would be more appropriate. Place the bindle or the white piece of paper included in the envelope under the patient's pubic area or buttocks and run the provided comb through the pubic hair, collecting any foreign material that falls out into the bindle. The comb and bindle should be packaged and sent even if there is not visible debris or material. Seal and fill out all information requested on envelope. Where there is evidence of semen or other matted material on the pubic hair, it may be collected in the same manner as other dried fluids. The swab should be placed in a small paper envelope and labeled possible fluid sample from pubic hair. Although this specimen may also be collected by cutting off the matted material, it is important to obtain the patient's permission before cutting any amount of hair. Step 7. Pubic hair standards. After much debate amongst the multidisciplinary members of the team that were revising the protocol, this step was determined to be appropriate to remain in the kit, with one major revision or condition. So, pubic hair standards are a pulled sample of the patient's pubic hair, a minimum of 30 hairs. This sample is not typically collected, with the exception of the following circumstances. 1. There is an unknown offender where a scene investigation by law enforcement is expected. Or 2. There is a scene investigation where evidence collection reveals a hair sample in need of the victim's hair for comparison purposes. In these circumstances, and with the victim's consent, pull a minimum of 30 pubic hairs from multiple locations using only gloved hands. Do not use tweezers as they may damage the hair shaft. Do not cut hair for the sample. Place the collected hairs in the bindle provided and envelope. Seal and fill out all information requested on the envelope. Step 8. Head hair standard. Again, after much debate, this hair sample step was also determined to be beneficial and remains a step in the Colorado kit. But it too is only to be done under the same conditions as the pubic hair standard. So, head hair standards are a pulled sample of the patient's head hair, a minimum of 30 hairs. This sample is not typically collected, with the exception of the following circumstances. 1. There is an unknown offender where a scene investigation by law enforcement is expected. Or 2. There is a scene investigation where evidence collection reveals a hair sample in need of the victim's hair for comparison purposes. So in essence, with both the head hair sample and the pubic hair sample, you'll only be pulling number 1 with the patient's consent and number 2 when there's unknown perpetrator identity. In these circumstances, pull a minimum of 30 head hair samples from multiple locations using only gloved hands. Do not use tweezers as they may damage the hair shaft, and do not cut the hair for the sample. Place the collected hairs in the bindle and envelope provided. Seal and fill out all information requested. Step 9. Anal swabs and smear. This step has not changed with the updated protocol. After fully explaining the procedure to the patient, put the patient in either supine or prone knee-chest position and apply gentle bilateral pressure with the examiner's hands to the patient's buttocks. Allow approximately 2 minutes for anal dilation to occur. Swab the anal cavity using the 4 swabs provided. To minimize patient discomfort, these swabs may be moistened slightly with sterile saline or sterile water. Prepare the smear by wiping swabs across the top, labeled surface of the microscope slide. The smear should not be fixed or stained. Allow all swabs and smear to air dry. Close and seal the slide holder and return to the kit. Dry and return the swabs to their appropriate envelope. Seal and fill out all information requested on the envelope. At this time, any additional examinations or tests, for example, STI testing, cultures, endoscopy, etc., involving the rectum should be conducted. Step 10. Vaginal or penile swabs and smear. This step has not changed with the updated protocol. For vaginal swabs should only be obtained in the adolescent or pubertal and adult population of female patients. Prepubescent patients or pediatric patients would have external genital swabbing only. When collecting the vaginal specimens, it is important not to aspirate the vaginal orifice or to dilute the fluids in any way. Utilizing a speculum in the patient who has reached the onset of menses, swab the vaginal vault using the 4 swabs provided. Prepare the vaginal smear by wiping the 4 swabs across the middle surface of the labeled glass slide. The smear should not be fixed or stained. Allow all swabs and smear to dry. Close and seal the slide holder and return it to the kit. Dry and return swabs to the envelope. seal and fill out all information requested on the envelope. At this time, the remainder of the pelvic examination should be performed, and any additional examinations or tests, for example, STI culturing, should be conducted. The collection of tampons as evidence. The sexual assault examiner may find that the patient has inserted a tampon in response to menstruation or bleeding post-assault, or the patient may have had a tampon in during the assault that they haven't yet removed. The tampon may have absorbed residual semen from the offender. It will therefore be necessary to collect the tampon as evidence. Obtain a sterile urine specimen collection container. Label the container with the name of the patient, date, time, and collector's initials. Punch 3 or 4 small 18-gauge needle air holes through the cover of the container. Carefully remove the tampon from the patient's vaginal cavity, or ask the patient to remove the tampon and place it in the urine specimen container. Cover the specimen container and place it into a paper bag. Label the bag with the name of the patient, date, time, and collector's initials. Seal the paper bag with tape and keep it separate from the evidence collection kit. Do not attempt to secure the tampon and packaging in the evidence collection kit. Refrigerate the specimen if transport to the laboratory is not immediate. Be sure to circle or highlight refrigerate on the front of the kit and notify law enforcement to ensure that the evidence will be properly preserved. The other item that I use to poke holes in the top of these container lids instead of an 18-gauge is one of those blunt needles used for drawing up medication. They work rather nicely because they're a little bit larger and they're nice and sturdy. Penile swabs. For the male patient, both adult and child, the presence of saliva on the penis could indicate that oral genital contact was made. The presence of vaginal fluids could help corroborate that the penis was introduced into a vaginal orifice, and feces or lubricants might be found if rectal penetration occurred. The proper method of swabbing the penis is to slightly moisten the 2 swabs provided with sterile water or sterile saline, and thoroughly swab the external surfaces of the penile shaft and glands. All outer areas of the penis and scrotum where contact is suspected should be swabbed. Allow all swabs to air dry, place both swabs in the envelope, and return to the kit. Care should be taken to avoid the urethral meatus, as this could result in obtaining DNA sample of the victim instead of the perpetrator. Any other applicable hospital testing, for example RPR, VDRL, HIV, etc., should be done at this time. Step 11. Cervical swabs and smear. This step has not changed. As with vaginal samples, cervical samples are only collected in patients who are past the onset of menses. The cervix provides an excellent source of sperm and DNA collection. The cervix serves as a reservoir for sperm, as the flow of cervical mucus creates strands that direct the sperm upward. Cervical swabs should be collected across the face of the cervix and slightly in the cervical os. This area is first visualized with a speculum. Then the area is swabbed by holding 4 dry swabs together and go across the face of the cervix. Prepare the smear by swiping the 4 swabs across the middle surface of the labeled glass slide. The smear should not be fixed or stained. Allow all swabs and smear to air dry, close and seal the slide holder and return to kit. Air dry and return swabs to the appropriate envelope. Seal and fill out all information requested on the envelope. Step 12. Fingernail clippings or swabbings. This step has not changed other than to put in writing that if clippings are not possible, swabbings are a second alternative. Fingernail clippings are commonly collected on patients which may have been in a physical altercation during an assault. They may contain skin cells of the suspect and are simple to collect. Use the clippers from the kit, and the nurse or patient may cut the fingernails onto the enclosed bindle. Nails from both hands should be included. When finished, close the clippers and include them in the bindle. Close the bindle and place in the envelope, filling out all requested information. If a patient has very short nails, declines having nails cut, or in the case of a child where cuttings could be difficult, a swab collection may be used. This is accomplished by moistening 1 swab with sterile water or sterile saline, and then using that 1 swab underneath each of the 10 fingernails. The swab is then air dried and placed in an envelope. Seal and fill out all information requested on the envelope. Step 13, buccal swabs. This step has not changed with the new protocol. In some instances of sexual assault, dried deposits of blood, semen, or saliva may be found at the crime scene or on the body or clothing of either the patient or the suspect. The purpose of collecting DNA sample buccal swabs is to determine the patient's DNA profile for comparison with such deposits. Prior to collection of the buccal swabs, have the patient rinse their mouth and wait 30 minutes before collecting the samples. Swab the inner aspects of both cheeks with all 4 swabs until moistened. Allow both swabs to dry. Place swabs in the appropriate envelope. Seal and fill out all information requested on that envelope. Buccal swabs should be taken in all acute sexual assault patients, including children. Step 15, an additional envelope. One additional envelope is included in the Colorado kit. Use clinical discretion as to whether it is a needed evidence collection component or not. This will vary based on the patient, history, and circumstances of the assault. For example, it may be appropriate to swab a female's abdomen when she says the suspect ejaculated on her. Other circumstances may exist where the additional envelope will be helpful, and the sexual assault examiner should use their best clinical judgment in determining appropriateness of inclusion. Each additional sample should be packaged in its own separate envelope. Seal and fill out all information as requested on the additional envelope. When more envelopes are needed than are provided in the kit, hospital envelopes or saved envelopes from other evidence collection kits may be utilized. House Bill 1020 went into effect as of March 2014. It contains a lot of new information, laws, and options. The law specifically states that no law enforcement agency nor medical facility can deny a victim of sexual assault the right to evidence collection. In addition to other choices, it gives patients the option to decide if their evidence will be analyzed or stored. Previously, this decision was left up to law enforcement. What is important for medical professionals to know is that they must provide informed consent. This is the consent form that is now contained in the Colorado Evidence Collection Kit. There are 4 areas that specifically need to be addressed. A completed form will have the appropriate law enforcement information at the top, your patient's initials in 4 areas, and the required printed names and signatures at the bottom. Please note, this form is for patients who are opting for full law enforcement reports or medical reports. Please don't use this consent form for your patients who are opting for the anonymous option. Now, let's go through each of the 4 major sections. After filling out the top of the form with law enforcement information, to include the law enforcement agency, an officer's name, a case number, and a contact phone number for the law enforcement agency, you should address the first section. Each of the next 4 sections will require a patient's initials. The first step simply states that the patient is or is not consenting to a medical forensic exam. If the patient does not consent, well then you're done. If the patient does consent, you may proceed. Have them initial that they consent and move on to the next section. The second area addresses reporting options. A patient can opt to make a report to law enforcement and actively participate in providing information to them and cooperating with a potential investigation. Or a patient can choose the medical reporting option. This is when they consent to a medical forensic exam but do not wish to provide information to law enforcement or cooperate with a potential investigation. Either way, have them initial which reporting option they are choosing. If your patient is under the age of 18, refer to your facility policy on how to handle this consent issue. If your facility does not have a policy regarding this, it's time to develop one. The third area for consent is the evidence analysis release of results section. This is certainly a new section with a lot of implications. In essence, patients now have the ability to determine for themselves if their evidence will be analyzed. As I stated earlier, prior to House Bill 1020, it was up to the discretion of law enforcement if the evidence was analyzed. Now patients make the decision. Evidence can be analyzed when patients opt for the full law enforcement report or the medical reporting option. Let's take a look at each option of analysis versus storage of evidence. 1. If a patient chooses to have their evidence analyzed, the responsible law enforcement agency has 21 days once they take possession of the evidence to get that evidence to a crime lab for analysis. Results of the analysis will be released to law enforcement. There is not a way for the crime lab to release the results directly to the patient. This means that if your patient has opted for the medical report, where they are not wishing to interact with law enforcement, if they want the results of their kit, they will have to interact with law enforcement at some point. And option number 2. If a patient is choosing to have their evidence collected but does not want it analyzed, it is up to the appropriate law enforcement agency to store the evidence. They must store evidence for a minimum of 2 years. Now, many agencies choose to keep the evidence longer due to statutes of limitations, but this will be determined by each individual agency. This is an option that some patients will opt for, and it is important that we respect and support their choices. Patients may, at a later time, decide to have the evidence analyzed. If they change their mind and contact you, you should refer them to the appropriate law enforcement agency. This last section is the withdrawal of consent section. This means that you, the medical provider, have explained to the patient that they have the option to withdraw consent for analysis. It is vital that you explain that if analysis has begun, it cannot be stopped. Your patient should be initialing here. An initial does not indicate that they wish to withdraw consent. An initial indicates that you have explained to them how to withdraw consent if they wish to do so at a later time. We have added language to this section that states it is only applicable to patients 18 years of age and older, as pediatric patients do not have the option for withdrawal of consent for analysis. Now, directly below this section is where your patient should print and sign with the correct date. You should also print your name, sign, and date, indicating that you are the medical provider providing informed consent and that you were the witness to the patient's choices and signatures. There are multiple copies of this consent form. The original stays with the kit. It goes inside the kit before you seal it. The yellow goes to law enforcement. Many medical providers paperclip this to the outside of the kit. And the pink remains with the medical record. The goldenrod color is for the patient. Anonymous reporting with evidence collection. The anonymous reporting option was developed with the knowledge that some sexual assault patients may want to have medical care and evidence collection, but remain totally anonymous to law enforcement at the time of receiving care. This option ensures that these sexual assault victims have the opportunity to preserve evidence that would otherwise be destroyed through normal activity. Although the patient is not participating in the investigation, she or he may choose to speak anonymously with law enforcement to obtain information. Anonymous reporting victims cannot have their evidence tested unless they convert to a medical or law enforcement report and provide identifying and contact information, which they may choose to do later. An anonymous kit cannot be tested due to the inability of law enforcement to follow up, if necessary, regarding testing outcomes. The examiner will notify law enforcement of the anonymous report, obtain an associated case or report number, and turn over the evidence kit with a unique identifying number to the law enforcement agency. The evidence kit is stored under the unique identifying number for a minimum of 2 years at the law enforcement agency, maintaining chain of custody from the date of the medical forensic examination. If medical or anonymous reporting patients ultimately choose to convert their case to a law enforcement report, they will provide the case or report number received upon hospital discharge to police, so the evidence may then be associated with the reporting victim and an investigation may commence. It is essential to recognize that any crime victim has the right to report the crime at any time following the commission of that crime. Whether the crime can be prosecuted is a matter that will be determined by the criminal justice system based on a variety of factors. Please remember, if your patient is opting for the anonymous collection, this is the consent form you should be using. You shouldn't be using the other consent form. This means that there will be 2 consent forms in the kit. You will always be using one of them. There's never a case where both consent forms should be used. Please also keep in mind, if your patient is opting for the anonymous collection, there should be no patient identifying information on anything that's given law enforcement. This includes the kit, the outside of the kit, and those consent forms. So if you utilize patient stickers in your documentation, please make sure that none of those are on anything that you're giving law enforcement. This also means that the medical entities will be the ones that can link the patient's name to the associated case numbers. It's vital that we maintain appropriate documentation of the patients and the case numbers in our medical record documentation. The incident form has been slightly changed. In addition to patient information and some of the assault details, we've added a section that allows you to indicate if there were multiple perpetrators, and a section indicating if the patient was menstruating during the medical forensic exam. Remember, this may be the only details the crime lab is getting regarding the assault. Please make sure it is filled out in its entirety. Again, the original stays with the kit. It goes in the kit before you seal it. The yellow goes to law enforcement, and the pink remains with the patient's medical record. We are nearing the end of this webinar, but before we conclude, I'd like to just briefly touch on a few issues that are prevalent in the patients that we see for medical forensic exams. First, drug-facilitated sexual assault. Alcohol is the #1 drug of facilitated sexual assault. It renders the person in a state in which they are unable to consent to sexual activity. Drug or alcohol-facilitated sexual assault should be considered in all cases in which a patient's medical condition appears to warrant toxicology screening for optimal care. For example, the patient presents with drowsiness, fatigue, lightheadedness, dizziness, physiological instability, memory loss, impaired motor skills, or severe intoxication. It should be considered in cases where a patient or accompanying person states the patient was or may have been drugged, and it should be considered if a patient suspects drug involvement because of a lack of recollection of events. Special instructions for processing of toxicological specimens may vary according to jurisdictional and facility policy. The specimens of choice for toxicology in a suspected drug-facilitated sexual assault case are urine and blood. It is recommended that a urine sample be collected from the victim if less than 120 hours have elapsed since the incident. If possible, 100 ml of urine should be collected in a specimen cup and stored refrigerated. The current recommendations by the Society of Forensic Toxicologists are that urine be collected in suspected DFSA up to 120 hours post-assault. Although most drugs will be undetectable in the blood more than 24 hours after ingestion, blood may prove useful in a DFSA case if collected less than 24 hours after the incident. A minimum of 10 ml of blood should be obtained in a gray top test tube containing the preservative sodium fluoride and the anticoagulant potassium oxalate. The blood should be stored refrigerated. Each biological specimen should be marked with the victim's name, date, and time of collection, and the collector's initials. Specimens should be sealed with evidence tape, and all relevant chain of custody protocols should be followed. Specimens should be submitted to a qualified forensic toxicology laboratory for analysis. So now that we've gone through the Colorado Evidence Collection Kit and the recent changes, let's review a couple of different scenarios that you may be faced with. One is the examination of people who are suspects in a sexual assault. Another is the examination and collection of evidence in someone who may be unconscious. The first of the special considerations is the evidentiary examination of the suspect in a sexual assault. Not all programs do this exam, but many are currently performing exams on suspects. There is even somewhat of a disagreement in programs as to whether the exam of suspects is purely evidentiary or legal in nature, much like drawing of illegal blood alcohol for police, or if it is medical in nature. Are you creating a healthcare encounter when you do your exam? If programs are doing suspect exams, there should be a specific policy in place for them. One of the primary differences in the suspect exam has to do with consent. Many programs will not proceed with a suspect exam without a search warrant or a court order directing them to collect the evidence from the body of a suspect. Some programs do obtain consent and then proceed with the exam, but best practice would be to obtain a search warrant before you proceed so that the suspect cannot claim that they were coerced into submitting to the exam by either you, the examiner, or by the police. Colorado does have specialized evidence collection kits for suspects, and you should use that kit if you have one. Follow the correct procedure, which will hopefully be a search warrant, collecting only the items that are indicated on the search warrant. If you see something that could be of value to the investigation of the case, you may point it out to the officer that is in the room with you when you are doing the exam, and the warrant can be amended to include the collection of that substance. Evidence from a suspect will include the same collection techniques as the victim. You would include areas where biologic or trace materials may have been deposited, as you do in the victim exam. Swabbing of the genital and/or pubic area will be the same as for the victim exam. Drying, packaging, and disposition of the evidence will be to the law enforcement agent requesting the exam. Forensic exam of the unconscious patient. There's actually controversy in the field on this issue. We bring it up here because it is something that you may face or may have already faced. So, what do we do with the patient who cannot consent for themselves? In the case of the patient who was brought in after an assault and there is evidence that surrounds them indicating that they were a victim, what do you do? There's a big difference of opinion on this. Some fall heavily on the side of this should never be done, and some are on the side of that it should be done, that you should assume that the patient would want you to do everything for them in terms of justice outcomes. I will not give you an absolute here. What I will say is that you should be prepared for this situation before it happens and have a protocol in place about it. Think about whether you will collect only and save samples or whether you will opt to never collect without consent. Use clinical judgment when able. For instance, what is the likelihood the patient will regain consciousness within evidence collection time frame and then be able to make a determination of consent? Think about your resources. Do you have an ethics committee or can legal weigh in? In any case, have a conversation, think about this, and be prepared for this scenario before it occurs. Once evidence collection is complete, evidence is placed into the kit. It is sealed, labeled, signed, and ideally turned over to law enforcement. If it is stored at the program, it must be maintained under chain of custody, and this may happen in some rural areas where law enforcement might not be available to respond right away. It could happen in urban areas where law enforcement is so overwhelmed and busy that they're unable to respond right away. And it's possible some programs may be storing kits for patients that have not made a decision to report to law enforcement. Some chain of custody basics for when you can't hand the kit immediately over to law enforcement. Don't leave the evidence alone and unattended. If evidence cannot be visualized by the person responsible for it, it needs to be secured in a locked area. Keep a paper chain of custody indicating who has had access and who has been responsible for that evidence, and keep it as short as feasibly possible. If you are not giving the evidence to law enforcement immediately, it can be securely stored, but that also must be documented on the chain of custody. And when evidence is transferred from one person to another, they must sign date and time when it was transferred. So in conclusion, some final thoughts. The major changes or additions to the collection of the kit are hair samples. With both head hair and pubic hair, you're only pulling hair samples with unknown perpetrators. We've also included an additional step, the external genitalia swab. This should be done on both male and female patients, can be done on adolescent and adult patients, as well as your pediatric patient population. And consent forms. There are now 2 consent forms in the kit, and again, to reiterate, you'll only be using one of the 2. The first one is for full law enforcement reports or medical reports, where law enforcement is getting the patient's name. These patients have the right to have evidence collected, and there are 4 areas to address. Number 1, are they consenting to the exam? Number 2, what's their reporting decision? Is it a full law enforcement report or a medical report? 3, are they wanting analysis of evidence or storage of evidence? And number 4, do they understand how to go about withdrawing consent if they desire to do so in the future? The second consent form is the anonymous reporting consent form. Anonymous reporting patients are those who don't want to give their information to law enforcement. They too have the right to evidence collection. The difference with this option is that they don't have the option of analysis of evidence. The anonymous option does have its own consent form and should be filled out in its entirety, but remember, only the copy that the medical record keeps should have any patient identifying information on it. The one that goes in the kit and that you give to law enforcement should not have the patient's name or information on it. The Colorado Sane Safe Project thanks you for taking the time to educate yourself on the updated Colorado Sexual Assault Evidence Collection Protocol. We sincerely hope that you found this to be educational and useful. If you do have questions, please feel free to reach out so that we may get you the answers you need. The full protocol as well as the consent forms can be found on our website. And check back regularly for more educational offerings.